And the next speaker is Dr. Arjun Kalyanpur, who is basically the chief architect behind the teleradiology solution and at Bangalore. Dr. Arjun, please. Primarily, he is a radiologist, and he will give you the essence of how he does from his Bangalore.
Good afternoon. I'd like to thank Dr. Archana and Dr. Pradhan for inviting me, as well as the Telemedicine Society. It's a pleasure to be here this afternoon. I've been asked to speak on international and rural models of teleradiology. You've just heard about how the technology works, and for the next 10 minutes or so, I'll be taking you on a quick round-the-world tour from Boston to Bihar and showing you that teleradiology can benefit someone in metropolitan city in the United States just as much as it can benefit someone in a very small town in rural India. But the reason why teleradiology is so important and why it's so necessary is because we have very significant and critical problems in radiology today in the form of a radiologist shortage, which is across the world. And this is coupled with an increasing use of radiology and increasing need for radiology services because we have more and more chronic diseases that require imaging. And our populations are getting older. The technology is advancing very rapidly, so the only missing piece of the jigsaw is really the radiologist himself or herself. Add to this the fact that most radiologists are concentrated in the metros, and we have a relative shortage of subspecialists, and it becomes a crisis. So we have delay in report turnaround and delay in patient care as a result. Now, if you look at the numbers across the world, the United States has about one radiologist for every 10,000 population. India has one for every 100,000. So, and the United States considers that it has a shortage of radiologists. So you can imagine how severe the problem is in India. Of course, we are better off than some of our neighbors, but the fact is we are in a very, very precarious situation at this point in time. So one solution that has been applied and which has been seen to be effective is the transfer of images to enable more efficient reporting and speedy reporting of scans. So the goals really here are to improve patient care by reducing the time to diagnosis, to reduce the cost of healthcare by utilizing manpower more efficiently. If you have a doctor working by day, it's more cost effective than having the same doctor working at night. And finally, you can optimize the efficiency of the radiologist and improve his or her quality of life by using teleradiology. So there are three scenarios where teleradiology has played a very significant role to date. One is in the emergency and trauma situation, which is where our organization, I think, has probably made its greatest impact. The second is subspecialty teleradiology. And finally, to provide services in remote and rural areas. And I'll be covering each of these three in the course of the next few minutes. So emergency teleradiology allows us to be able to report a scan from Bangalore, which has been acquired anywhere in the world within 30 minutes. That's the beauty of the process. In fact, it's as low as 15 minutes for a patient with an acute stroke. So the advantage is obviously the short turnaround time for the report. Add to this the economy of scale. If you have a radiologist reading from a centralized institution who is reporting for multiple hospitals at the same time, that saves the cost of having one radiologist in each of these institutions. And then when you take that radiologist and put him on the other side of the world, the night gets converted to day, and so your radiologist is more productive, and your cost of care also drops. So the advantages really are in improving quality of reporting, increased productivity of the radiologist, the economy of scale, and the availability of support staff, which is easier obviously in a day scenario than in a night scenario. There are certain regulatory issues which have to be dealt with when providing international teleradiology services. So for instance, if you're providing reporting to hospitals in the United States, your radiologists have to be certified by the American Board of Radiology. They have to be licensed in the state where they're providing services. Similarly, in the United Kingdom or in any part of the world, the local certification is a must. You have to have medical legal insurance. You have to demonstrate that you're HIPAA compliant. and you have to follow a certain standard. The worldwide standard typically is the ACR standard, the American College of Radiology, but the European Union has its own standards as well. Finally, if you have a certificate of accreditation by something like the Joint Commission, then that's an added feather in your cap. So our organization, for instance, has a group of 12 radiologists who are certified and licensed in the United States, providing services to these hospitals. Now, turnaround time is a very, very important issue in teleradiology. And really, the term is a relative term. It depends on what is the requirement. So obviously, in the setting of an acute stroke, the turnaround time has to be the shortest possible. And currently, stroke centers in the United States have a requirement of 15 minutes from the time the scan is acquired till the report is delivered. So that's what we're required to comply with. And it's possible. There are studies that are now currently underway which show tremendous improvement in patient outcome because of the fact that the report is turned around immediately and thrombolysis can be administered, reducing the burden of neuronal death in the setting of acute stroke. Standard emergency reports are turned around in 30 minutes. Inpatient and outpatient reports proportionally longer. Of course, the bandwidth is a critical issue in our country. That's always a challenge. And when you're selecting your provider, you have to be very, very careful. Typically, you have to build in multiple layers of redundancy into your network. The use of compression technologies has been tried and has been found effective. You can compress medical images to up to 10 to 1 compression without losing significant diagnostic data in the emergency setting. Obviously, in the setting of certain situations like mammography, you wouldn't want to use it, but in an acute care emergency environment, it can be used very effectively. I'm not going to talk too much about the workflow. My colleague Ankita Puri will be talking about it a little bit later, but that is really a critical element in teleradiology, optimizing the efficiency of the radiologist. When you're in a situation where your radiologists are in short supply, you have to optimize their productivity. The quality of the image is paramount, and there has to be an effort to ensure that there is no data loss in the transmission. So these are some of the challenges with international teleradiology. One place where we found it to be very effective is in the setting of war zone teleradiology. We were providing services to a center in Georgia, which is one of the republics of the USSR, and they were invaded, and suddenly we found ourselves doing trauma radiology for people who were critically injured. So that's a place where it can make a big difference. In certain parts of the world, for instance, Singapore, we've made a huge impact by reducing the waiting time. It took 3 days for an X-ray to be reported at one of the polyclinics in Singapore before teleradiology was implemented. Now that turnaround time we've been able to reduce to 1 hour. And you can see that the number of scans reported has gone up year on year to the point where it was mentioned in a speech in Parliament by no less a person than Mr. Lee Kuan Yew. So this is something that Singapore has embraced very successfully. And I think that the reason why it's been so successful there is because they've had a strong buy-in both from the governmental side as well as from the physician side, which is always helpful. Subspecialty imaging is also another application of teleradiology. You bring the images to the most qualified subspecialist, could be a cardiac radiologist or neuroradiologist. This increases the quality of the reports. Currently we are doing reporting of cardiac MRI from Thailand, PET CTs from Denmark, and a variety of other subspecialty reporting. Virtual 3D labs, another application of international teleradiology. The basic concept here is that you have very large image data sets which need to be manipulated by a technologist. The technologist is in short supply, particularly at night. If the images are transferred to a remote location where the workstation is available, they can be post-processed remotely and then sent back to the site. Quality is the key determinant for survival in teleradiology. It is non-negotiable, and teleradiologists are typically held to a higher standard than local hospital radiologists. So one has to be very introspective in terms of one's quality data. One has to be very transparent with it. And this is a publication which we recently had published in the journal Emergency Radiology, where we reviewed and audited all our quality statistics over a year. Continuing education and training, I understand Dr. Archana will be speaking about this, but in the teleradiology environment, it's particularly important, I think, because radiologists are working typically in isolation. So it's necessary for them to remain connected with their specialty as well as with the rest of clinical medicine and to constantly update their knowledge. Since the radiologists are so far-flung and spread out, the use of innovative techniques like e-learning and web conferencing are particularly important to make sure that the learning is disseminated. The use of teaching websites, this is one that we have developed ourselves, is also extremely helpful in this regard. Some of the challenges in the international environment, protectionism, lack of awareness, fear of losing one's job, a lot of it is to do with not understanding what the benefits can be. So I think as our experience has been that these tend to go away with time. Second part of my talk is on teleradiology with remote and rural areas, particularly important in India where you have the technology but no radiologist on site, and it costs a lot to transport the radiologist to the patient to another location. We have few centers of excellence. It's a large country. We really need a solution that embraces technology and allows low-cost diagnostics to reach remote parts of the country. So our challenge, I think, would be to be in a situation where we can interpret an X-ray from every public health center, primary healthcare center, ultrasound, CT at every district hospital, and avoid a situation like this where somebody has to get on a train and go to the city just to get a diagnosis. The diagnosis should be available where the patient is, and the patient should only have to travel, if at all, for treatment. These are some of the projects that we've undertaken which have been successful. This is one on pediatric telesonography, a center in Bijapur, where you can see the patient, the child is being scanned, and the images are being transmitted over this video phone to our center in Bangalore, where our radiologist is able to view the scan as it's done in real time, and even guide the probe, the direction of the probe by advising the technologist in which direction to point it. This is an echocardiogram, but this can be equally successfully done with any type of ultrasound exam. We report CT scans and MRI scans for a hospital in remote northeast of Itanagar through a teleradiology link. This has been going on for over 5 years now, and it's been very successful. And this, this is a very remote part of the country, tribal population. You would think it would be difficult to get bandwidth, but the bandwidth they have is sufficient for them to be able to get a report within a couple of hours from our center. This is a tribal hospital in rural Karnataka, which has a high TB and HIV population, using a regular conventional X-ray unit and a flatbed scanner. We're able to interpret their X-rays for them. So what we really need in India is, I think, increased awareness, which is why symposia like these are very important, increased governmental support and lower cost technologies. The future really is in greater penetration, greater convergence and greater spread across the globe. And equipment such as this, where you combine available laptop technologies with healthcare devices like this ultrasound probe, are very important and helpful. The role of teleradiology continues to increase, plays a critical role in emergency diagnosis worldwide, and as I mentioned, it can benefit someone in a metropolitan city just as much as it can benefit someone in the remote parts of our country. Thank you very much for your attention. When you set up an infrastructure for teleradiology, you need to account for every possible outage. So say you have a fiber cable, you should have a backup internet provider which is using radio frequency or satellite, because if the fiber gets cut, you have to have something which is completely redundant. So I think extreme redundancy is really the answer to your question. Yes.
Redundancy failure.
It depends entirely on your infrastructure, as I mentioned. I mean, I think it's possible to have 100% uptime if you have the proper redundancy measures in place. There's no reason why you shouldn't, and in fact that I think has to be the goal, because ultimately you're dealing with critical care scenarios and you really cannot afford downtime. So the only way is to have redundancy. Yes, sir. Is
the malpractice indemnity insurance for teleradiologists, does it differ from that for conventional radiologists in the US? All your consultants are board certified radiologists. So is the premium they pay equivalent to that of US based radiologists? Is it different? And are there Indian insurance companies who are willing to provide you with a malpractice?
Great questions both. The answer to the first is that it's approximately the same. It's not that it's significantly increased for teleradiology. There are certain challenges though. The number of companies willing to insure a teleradiology provider will be less than for a regular radiology provider. So you have to do a little bit more searching.
Are they Indian-based companies or overseas?
We have, for instance, for our Singapore coverage, we have an Indian-based company covering us. But for coverage in the United States, we have to have a US-based company ensuring us.
What do you think of the pattern recognition techniques by computers to compensate this lack of radiologists?
That, I think, is the way of the future. You're talking about computer-aided detection, and we're doing some research in that space with some of the big technology companies. I think eventually that is the way we are headed, unless we're able to train more radiologists, which I don't see happening in the short term. The issue today is that the CAD technologies that are available are fairly rudimentary. They're only really effective in things like mammography and lung nodule detection, a couple of very specific scenarios. So I think we're still a far cry from the day when a computer will replace a radiologist. There's also a certain human element to radiology, which I don't think a computer will ever be able to completely replace.
It can go for an intelligent system also.
Absolutely. I think it can certainly make the radiologist much more efficient. I don't think it will completely replace.
And we use it as a second opinion.
Absolutely. I think that's a very good point you raised.
There's a shortage of radiologists worldwide, and you are a group of 12 radiologists. What is your workload?
Actually, we're more than 12. I only showed you our American board certified radiologists, but we're actually a group of about 45 radiologists. So we have other radiologists who are trained and licensed in the United Kingdom, others who are trained and licensed in India. So we have different subgroups for our different operations. Having said that, I think you bring up a very valid point. The number of radiologists is finite. So there are only two possible scenarios. One is to make the functioning of those radiologists more and more efficient to the point where the same radiologist can do 2x or 3x the amount of work without perceptibly feeling eye strain or ergonomic issues. So that is one big challenge, optimizing efficiency in workflow. The second challenge is, I think, very efficient training of radiologists, to bring radiologists into the pool at in shorter and shorter periods, so that you can have competency, basic competency, without necessarily aspiring for extreme excellence. So I think that's something that we're still trying to figure out in our training environments. But I'm glad that both those topics are going to be addressed in the coming session. Thank you.
Just one last question. What mode of reporting do you prefer? Typing your own report, the dictaphone, or probably having a transcriptionist scribe for you?
So the answer is all of the above. We use all of these, different radiologists within our organization have different preferences, but all three tools are available. I myself use a combination of all three, depending on the particular environment.
Which do you find more efficient in terms of?
I think each has its merits and demerits, so I think the most optimal way to function is to have all three available and use them as and when required. Having a live transcription is extremely helpful in terms of having that individual to proof and correct. But the use of macros and standard format reports is also very efficient, especially if you're working from, say, a home office or something like that. I find that to be a very useful tool. And of course, voice recognition is now improving by leaps and bounds, so I think that's a very